Okay, good morning and welcome to the Spotlight poster session for Survivorship, biomarker predictors and other survival-associated factors. I'm Lindsay Peterson of Washington University in St. Louis, Missouri. It's my pleasure to be here this morning. We have some really great posters to review this morning. Please submit your questions either through the app or at the microphones at the Q&A session. Our first presenter is Dr. Neil Iyengar. He is a breast medical oncologist, associate professor, and leads the Healthy Living Center. I knew I was going to do that. Healthy Living Center at Memorial Sloan Kettering Cancer Center.
Good morning. Thank you, Dr. Peterson, for that kind introduction. It's my pleasure to be here this morning and present some exciting work from the first 4 abstracts of this morning's session. Congratulations to the authors for being featured in this morning's session. I'm going to try to go through this as efficiently as possible because we have a lot of data to get through. Here are my disclosures, and I'd like to go ahead and show you some background data before we jump into the meat of this morning's session. So there have now been several data sets which have been published indicating that adiposity is a predictor of response or outcomes after treatment with chemotherapy in early stage breast cancer, and some data even in the metastatic setting. This is one of several representative studies that I'm showing you here that was conducted in a Japanese cohort in patients who received neoadjuvant anthracycline-based chemotherapy. And in the Kaplan-Meier curves on the right there, you can see on the top subcutaneous fat area that's quantified by volume, and visceral fat area on the bottom, similarly quantified by volume. When we look at the more bioactive fat tissue, the visceral fat, we see that those patients with higher levels of visceral fat, 100 centimeters squared or greater, have worse outcomes in terms of distant disease-free survival, with a similar trend noted in the subcutaneous fat area, raising the hypothesis that the activity or quality of the visceral fat tissue may impact response to chemotherapy and other cancer treatments. Now, when we look at toxicity, we also know that adiposity is a predictor of toxicity. There have also been several studies indicating that toxicity is increased in the setting of excess adiposity, whether that's classical obesity or body composition measured. This is a study that measures the skeletal muscle gauge, which is essentially a measure of fat tissue infiltration into skeletal muscle. And if you take a look at the cross-sectional imaging there, you can see 2 representative images demonstrating an individual with a high skeletal muscle gauge, which is what we want. That's the nice red homogeneous appearance that's been colored in there. And the individual on the right side has that sort of mottled appearance demonstrating an infiltration of excess fat tissue deposition in that skeletal muscle. When we look at associations with toxicity here, you can see that there is an association or trend to more toxicity, numerous different toxicities with a lower skeletal muscle gauge or with more ectopic fat deposition in the skeletal muscle. Particularly if we look at hospitalization, I think that's a nice summary of the impact of excess adiposity on toxicity. So certainly these findings help to support the hypothesis that perhaps improving adiposity may improve not only breast cancer-specific outcomes or response to breast cancer treatment, but may also improve the patient experience and toxicity associated with cancer therapy. So with that being said, and this is a summary image here which summarizes all of the, not all of them, but several of the comorbidities associated with obesity. And we'll go through some data here, starting off with a retrospective cohort study that looked at the effect of weight management therapy on cardiovascular outcomes after breast cancer diagnosis by Dr. Wooster and colleagues. Then we'll look at the use of GLP-1 receptor agonists in another retrospective cohort study in the survivorship setting in a large cohort of patients treated at MD Anderson Cancer Center by Dr. Sukumar and colleagues. We'll then shift a little bit from adiposity to musculoskeletal toxicity. We know that this can be a major issue with aromatase inhibition, and any efforts to identify biomarkers of toxicity or targets for therapeutic interventions would be valuable to clinical practice, and we'll see some of that data from a GWAS study by Dr. Lapidari and colleagues from the CANTO prospective cohort. And finally, we'll finish with Dr. Johnston's secondary analysis of a completed randomized control trial that tested a dietetic and nurse-led survivorship intervention using an EPRO instrument to trigger dietitian referrals. So let's start with Dr. Wooster's data here. So as I think we're all familiar with, cardiovascular events, including myocardial infarction, are increased, or the incidence and risk are increased in those patients who've been diagnosed with breast cancer due to several mechanisms, certainly treatment-associated, but also some of the metabolic dysfunction that's associated with carcinogenesis itself. And here, this was a study that looked at a cohort of over 35,000 patients who were overweight or obese and had completed their breast surgery for invasive breast cancer. And you can see here that 7.1% of patients received some kind of weight management therapy. And as you might expect, this was most frequent in those individuals with class 3 obesity, 9.6% in that group. Weight management therapy here was classified as nutrition or lifestyle counseling, bariatric surgery, or a medical approach. Within 1 year of surgery, 457 cardiovascular events were noted, and this was predominantly in the group that did not receive weight management therapy. You can see that only 19 patients in the weight management therapy group had a cardiovascular event. So that low rate, 0.8% rate of cardiovascular events in the weight management therapy was significantly lower than the 1.3% in the no weight management therapy group. Noting that this is within 1 year, so this is pretty, we're talking about a short interval here, within 1 year of the breast cancer surgery and presumably diagnosis. So let's take a look at some trends over time here. And what you can see, just as an eagle eye view here, the purple line is demonstrating weight loss medications. The gray line is nutrition counseling or therapy, and the blue line is bariatric surgery. And there is an increase in all of these strategies for weight management, but if you look at the slope of the curve of the purple line, there's clearly a dramatic increase or acceleration in the rate or utilization of weight management therapies. So the authors conclude that weight management therapy in people diagnosed with breast cancer has increased over time, as I just showed you, particularly weight loss medications. I note that the use is still less than 10%. The overall cardiovascular event rate was low, and again, this is within 1 year of breast surgery, but it was lower in those individuals who received weight management therapy. So I think there are some, this is very intriguing data, but there are some key questions that longer-term follow-up will likely address here. Certainly, we know that the risk of cardiovascular events accumulates over time. So what's the impact in the long run for weight management therapies, and particularly looking at this stratified by the types of weight management therapies? The impact of different breast cancer therapies on the efficacy of weight management therapy, and we'll get into that in subsequent presentations. And then ultimately, the impact on cancer-specific outcomes would also be of interest. So with that theme, we'll move on to a currently popular weight management therapy, and that, of course, is the incretin mimetics. We had a session on the use of these drugs in the risk reduction setting yesterday, or was that 2 days ago? I can't remember. It's all blurring together. But here, this is a nice retrospective study, the largest retrospective study or data set that is looking at the MD Anderson experience of GLP-1 receptor agonists, both single and dual, in breast cancer survivors, presented by Dr. Sukumar and colleagues. So you could see the baseline characteristics on the left there. It might be a little small, so I encourage you to check out the poster here. But it was over 1,000 patients with stage 1 to 3 breast cancer who had received a GLP-1 receptor agonist for 3 months or more. And this was a very statistically robust methodology here. Propensity score matching was used to match those patients treated with the GLP-1 receptor agonist in a ratio of 1 to 2 to control patients who did not receive the drug. Several matching factors were used, including body mass index, type 2 diabetes, age, stage, and receptors. I do point out that I think this is very critical here because there are many confounding factors when we look at observational data and the use of GLP-1 or any diabetic drugs and their impact on outcomes. So this is kudos to the authors for this design here. Median follow-up time was 4.7 years, and the median duration of GLP-1 receptor agonist was 1.2 years. The median time from breast cancer diagnosis to initiation of incretin mimetic therapy was 4.4 years. And here now you can see the rates of use here. So 38.1% of patients received the single agonist semaglutide or the dual agonist tirzepatide. Median weight loss at these time points is listed here. So at 12 months, ultimately, the weight loss was minus 3.1%. And again, cautioning about cross-trial comparison, but just thinking about the phase 3 data reported in the non-oncology setting for these drugs being far greater than that, 14 to 15%. Tamoxifen or AI use, as you might expect, was associated with weight gain, an average of 2.3 kilograms over time, and that was statistically significant, raising the possibility that endocrine therapy may attenuate the efficacy of the incretin mimetics for weight loss. The authors were also able to look at cancer-specific and all-cause outcomes here. And you can see here that median disease-free survival was 27.5 years in the GLP-1 receptor agonist group and not reached in the control arm. This was not a statistically significant difference. In terms of overall survival, there was a significant difference here favoring the GLP-1 receptor agonist arm where median survival had not yet been reached versus 24.1 years in the control group. So the authors conclude that GLP-1 receptor agonism is associated with modest weight loss, consistent with our own experience at MSK, but a much smaller cohort, which we presented over the summer. So happy or pleased to see some consistency of the data, but it really raises the question of why are we seeing these lower rates of weight loss in these groups of patients. And that gets to the second bullet point here. With this much larger cohort, the authors were able to address this question to some degree, and with the data suggesting that it may be the endocrine therapy that's attenuating the weight loss effect. We can talk by the posters about potential mechanisms. And in this study, cancer-specific survival was not improved in the GLP-1 receptor agonist group, whereas all-cause mortality was improved. So some questions remaining here. I raised this the other day, but I do think that dosing is a key question here. We know that there's certainly different dosing for diabetes indication versus weight loss indication. We also know that the drug can be titrated to target the ideal amount of weight loss here. So can we use these drugs in a way that overcomes perhaps that effective endocrine therapy and achieve that 10% or greater weight loss that Fabian and colleagues have published as a necessary threshold for reversing some of the negative impact of obesity on tumor growth. I do think that combining with a lifestyle intervention is critical. We know that the weight essentially comes back once these drugs are stopped. So what was the weight trajectory over time in this cohort and the on and off usage of these drugs would be of interest, and ultimately prospective randomized controlled trials are needed. Let's now shift gears to muscle, and we'll talk about musculoskeletal toxicity by an interesting study by Dr. Lapidari and colleagues looking at or using a genome-wide association study to identify gene alterations associated with AI musculoskeletal toxicity, and we know that this is a major cause for low adherence or difficulty taking the aromatase inhibitors. And there has been some preliminary work suggesting that germline variants in genes that regulate inflammation, bone turnover, estrogen metabolism may be involved. Certainly the pharmacokinetics of AIs may contribute to the musculoskeletal toxicity. So in this cohort, which is the prospective CANTO cohort, which in this particular study included over 4,000 patients, close to 5,000 patients, who were postmenopausal on adjuvant AI. This is where the study was conducted. And an AI musculoskeletal toxicity was defined as any grade articular or muscular pain. So the authors looked at associations between quite a few, over 1 million SNPs in blood samples and their associations with that toxicity. The baseline characteristics are on the table there, but again, encourage you to check out the poster. I would say overall, the rates of AI musculoskeletal toxicity and the grade of AI musculoskeletal toxicity are consistent with what has been previously been published, and I would also say with clinical experience. So when we look, I know this is a lot of data here, but ultimately the bottom line is that the authors were able to identify several SNPs in their models that were associated with the reporting of AI musculoskeletal toxicity. And here you can't really read it, but if you visit the poster, you can see that some of these SNPs are associated with pathways that have been previously postulated to be associated with AI musculoskeletal toxicity, although some of them are less clear in terms of their mechanism and function. So ultimately, the authors conclude that in this exploratory study, there are several SNPs that are implicated in AI musculoskeletal toxicity. I think this is a very interesting initial step, and certainly we need to interrogate what the authors have identified to better understand the functional and mechanistic roles of these alterations and whether or not they can be used as predictors of AI-associated musculoskeletal toxicity, ideally if they can also be used as a target for intervention, particularly if we're thinking about anti-inflammatory or other interventions in a selected group, that might also be useful, and ultimately validation in independent cohorts as well as potentially prospective trials if we're testing an intervention. So finally, we'll go through Dr. Johnston's data, which I think to some degree brings together a lot of what we've been talking about here in terms of interventions that we can ultimately use, or a platform perhaps to identify those patients who need interventions. So this was the Linking You to Support and Advice randomized control trial, which tested a survivorship platform in patients with early stage breast cancer here. This was a secondary analysis of the trial, so the trial did demonstrate that this platform, this survivorship platform, was feasible in 200 patients. This secondary analysis looked at 148 patients with hormone receptor positive. Oh, I got the please wrap up sign. I'm going to try to wrap up really quick. So this was 148 patients with hormone receptor positive stage 1 to 3 breast cancer on adjuvant endocrine therapy. And ultimately, the primary goal of this secondary analysis was to look at the impact on body composition. I won't take you through the full schema here, but the bottom line is if you look at the algorithm on the right there, they used an EPRO mechanism to identify patients who were at high risk and needed nutrition counseling, either because they scored high on a malnutrition score or they had a high BMI. And ultimately, this was high risk for further gaining weight, and this triggered a dietitian consultation and intervention. The authors looked at the impact of the intervention versus the control arm patients on various body composition and anthropometric measures, as well as functional measures, including muscle strength. So ultimately here, they did not find a significant difference in body weight, waist circumference, lean mass tissue, or adipose tissue mass, or hand grip strength. However, I will note that this is a secondary analysis, so not necessarily powered to those endpoints, and the trends look interesting, supporting further study in a powered trial for those endpoints and whether or not we can improve those endpoints through an EPRO identification or risk stratification method. At 12 months, weight gain concern increased to 72% of patients in the control or comparator arm, but it actually decreased from baseline to 52% in the experimental arm, which was a significant, or not quite a significant difference here, but that effect size is actually fairly large, suggesting that the hypothesis might be true and warranting further study here. So ultimately, the authors conclude that the dietetic intervention triggered by an EPRO risk assessment method within a survivorship intervention is feasible in early stage hormone receptor positive breast cancer and may improve weight gain concern. And as I've mentioned, this was an exploratory analysis, but the findings are encouraging and warrants larger efficacy trials. But it does raise the question of should we be using more intensive interventions here. And because I've run out of time, I won't take you through our intervention, but I will note here that you can look at an intervention that we conducted in the same setting, which was a very intensive personalized plant-based diet plus a structured exercise intervention in the same type of population here, hormone receptor positive on AIs. And we actually found a 15% global weight loss with a precision diet and exercise intervention, including 7% increase in lean mass. This was early days, so that was only at 6-month follow-up. We'll see what the long-term follow-up is. So it is feasible to use a lifestyle intervention to induce more weight loss than what we are actually seeing with some of the incretin mimetics in this population as well, and I think that's notable. I'll leave you with these key findings here. I think I've summarized all of them, and I thank you for your time.
All right, thank you, Neil, for that great discussion. We're going to open up for questions. There are a couple microphones here. I'll start with one online, but please come to the microphone if you have any questions. So we have a question first regarding the GLP-1 study. So obviously, we all know endocrine therapy leads to a lot of weight loss in our patients, and here in this study, we're seeing that there's a significant reduction in the amount of weight that we would expect these patients to have lost had they not been on endocrine therapy. What are our suggestions for these patients, and how can we help them meet their goals?
Yeah, thank you. I think that's a really important question because in clinic, we see every day that patients are gaining weight on endocrine therapy. And not unexpected, in our cohort, we found that patients on endocrine therapy had attenuated weight loss with concurrent GLP-1. And so, the study was retrospective and there's some limitations, but it does fit with what we would expect clinically. I think we need to encourage lifestyle interventions concurrent with pharmacologic therapy, encouraging a healthy diet and exercise. There's many studies that show that doing effective lifestyle interventions can actually cause significant weight loss, 5 to 10% of weight loss. And so we need to have a combination approach.
Okay, and here at the microphone.
Thank you. I'm a breast oncologist and epidemiologist from Beijing. I have a quick question for Dr. Wooster. First, what's the definition of weight management therapy? And second, since we do have many shared risk factors between breast cancer and cardiovascular disease, we do interested in what kind of shared risk factors did you account for? And the third, did you get a chance to look at different CVD subtypes, since heart failure and stroke, they might be different. So, and I do have another question for, did you account for other lifestyle-related factors like physical activity?
Thank you, that's a great question. So in terms of weight management therapy, this was divided into 3 categories, the first being nutritional counseling. So if we go back to that graph, that was the gray line, which had the highest frequency. The next was weight loss medication, so that included GLP-1s and also non-GLP-1 weight loss medication. And the third category was bariatric surgery, which you saw was kind of not really changed over the duration of the study. I think you were asking about if we could account for other variables like physical activity. So, given that this is a large population-based database, using MarketScan, and we're really using claims data more than anything, it's hard to know exactly from an individual level what patients were, what could be contributing. I suppose it would be interesting if there were, let's say, physical therapy referrals, for example, but that was not something that we included in our study, and I think that would be a little bit too complex for this. But I think it's a really, really great question for future studies.
And the question for subgroup analysis regarding CVD subtypes.
Regarding what?
The cardiovascular disease subtypes. Did you get it? Like for heart failure and...
No, we grouped them together. For so cardiovascular events were taken as one. So in terms of like myocardial infarction, is that what you're asking? Yeah, we looked at it as one.
Okay, thank you.
Yeah, thank you.
Okay, there's a question online regarding intermittent fasting and exercise. It came through when we were discussing the aromatase inhibitor study, and given what we know about exercise and the improvement in aromatase inhibitor musculoskeletal symptoms, I'm assuming it's related to that study. So they're also asking about intermittent fasting. So we obviously have some very interesting data with intermittent fasting and chemotherapy-related side effects, even chemotherapy efficacy. So I will put that question to Ms. Johnston about the, to the GWAS study in terms of any data on intermittent fasting and exercise outside the purview of your study, but do you have any information on that?
So, thank you for the question. For physical activity, in our court, we have this kind of information. And in a previous poster, we showed the uptake of physical activity in our court and its association with the musculoskeletal toxicity. So we saw that basically patients with kind of toxicity were more likely to adopt physical activity to manage this kind of symptom. So the idea, yeah, exactly, is that if we detect earlier patients with predisposition to musculoskeletal toxicity, we can push and we can foster this uptake. But we don't have data about fasting in this setting.
Sure. Okay, wonderful. All right, any other questions? We'll have you come to the microphone. There's a couple more here online. So one question regarding insurance approval for GLP-1s. We have a lot of patients who ask for these in clinic. Not all of them meet the classic criteria. So I'll really open this up to anyone in terms of any tips for helping patients get approval for these medications.
Yeah, I don't have the perfect answer. I know it's really a critical issue across the world. I think there's a lot of disparities in access with all novel therapies, but now we have data in GLP-1 drugs as well. In patients, in the general adult population and patients with cancer, without cancer, there's been studies showing that there's socioeconomic disparities and racial disparities in access to these important treatments. This is critical because these are improving overall mortality and mitigating cardiovascular risk. So I don't have the perfect answer, but it's a crucial issue.
Neil, your experience?
I'll just add to that. I completely agree. I mean, these are incredibly important issues. One of the issues or problems, I would say right now, is that the indication for GLPs, which are essentially obesity plus a qualifying comorbidity, cancer is not a qualifying comorbidity. I don't necessarily want to qualify that as a problem because we need to generate the data to show that it should be a qualifying comorbidity, and I think that's why the data that Dr. Sukumar has generated and that prospective randomized control trials will need to generate could lead to the addition of cancer as a qualifying comorbidity. But for now, without that data, we are limited to the indication. One thing I will say, though, is we have to be careful because we know that a lot of patients are getting access, and this leads to the disparities issue, but several patients are getting access through compounding pharmacies as well, and of course quality control is a major issue there, and so I've started to actually ask my patients that would qualify on a weight loss indication if they're taking it, and specifically if they're getting it from a source other than a traditional pharmacy.
Yeah, I think that's really important to discuss with patients. I think a lot of them don't truly understand the difference between the compounded versions. So I'll ask another question regarding the PRO data. So this is interesting. We obviously saw Pro-B yesterday, and we're seeing some really interesting data come out with these PRO collections. Neil alluded to the fact that maybe there's a hint of a difference there. Is there any suggestion that the experimental arm underperformed, or perhaps that the control arm overperformed, leading to not quite as big of a difference as you might have expected?
Yeah, that's a very good point. I suppose we didn't have a true control arm because they were getting a survivorship treatment summary and care plan at baseline. So they were getting more than the standard of care. So that's why they weren't our true control arm. So we are looking at the differences there. I suppose as well, knowing that in 12 months' time, you're going to come back in and see a nurse and a dietitian, that might give you a bit of a goal to then sort of work for those 12 months. So it is something that we have considered. Again, as a result of this trial, we have a clinical nurse specialist in post, and we're looking at patient-initiated follow-up. So allowing the patient to make that call of, okay, we'll check in with you at baseline at 6 months, and then at 12-month follow-up, at which stage we'll discharge you. So it's definitely something that we looked at and we considered.
There's a comment here, really, I think, regarding that a lot of these studies are retrospective, and so how confident are we that the outcomes are what they are because of what was done, or are these patients otherwise engaged in healthy habits? So obviously we need prospective data, but a lot of these retrospective studies obviously do their best to control for all of these confounding healthy habits. So if there are no other questions, we're going to wrap up and we'll move on to our second session. Thank you, Neil, and thank you to all of our poster presenters. So we'll have our second group of poster presenters come up. Okay, so we'll move on to our second discussion. We have Dr. Maryam Lustberg from the Yale Cancer Center. She is the chief of breast oncology and breast medical oncologist, and we'll have her discuss the second round of posters for us.
Good morning, everyone. Thank you, Dr. Peterson, and thank you to all the authors of the next 4 wonderful abstracts. The first series were also wonderful, so congratulations. 2 of my mentees were in the first session, so I'm just really proud of both Drs. Jasmine Sukumar and Pietro Lapidari. So I'll be discussing predictors of survival, and my disclosures are listed here. Thankfully, we have a growing number of cancer survivors in the US as well as globally. These are updated data that were just recently published by the lead author being the head of NCI Cancer Survivorship. On the right, you can see we also have a growing number of patients living as survivors with metastatic disease. You can see the breast numbers there, both de novo as well as recurrent disease. And again, highlighting for those who are less familiar with the field of cancer survivorship, that a cancer survivor is defined from day 1 of diagnosis throughout their life. With survival, we have to certainly take into account multiple long-term toxicities of cancer itself, as well as our cancer therapies. And multiple systems can unfortunately be affected that impact quality of life and can also impact survival. So as we go through kind of our meeting, even here in San Antonio, you can see certain tracks are very much focused on therapeutic efficacy and survival, and then we have sessions like this focused on survivorship. But truly, I hope as you hear about the next series of abstracts, we really come together that this is a more holistic view of survival outcomes as well as quality of life is a much more comprehensive way of thinking about how to best take care of our patients. Multiple predictors of survival have been looked at, and I think these next series of abstract really do a nice job focusing on different aspects of survivorship domains based on the NCI Cancer Survivorship framework. As I discuss these abstracts, we'll be discussing, for example, recurrence and secondary malignancies, physical effects of therapies, psychosocial effects, chronic conditions, and health promotion. So these next 4 abstracts, the main theme that ties them together is that they nicely address all the different survivorship domains that have been previously published. The abstracts are here, and I will go through them one by one. Starting with the poster by Dr. Gupta and Dr. Gandhi from Roswell Park. This was a SEER registry data analysis looking at patients with all stages of breast cancer with mortality data from the years 2010 to 2019. In the final analysis, close to 500,000 patients were included. So I'll start out first with early stage non-metastatic breast cancer, and you can see there different associations, different risk factors that were identified as being significant for having increased odds of breast-related mortality, and that included older age, being non-Hispanic African American, as well as having hormone receptor negative breast cancer, both HER2 negative as well as HER2 positive breast cancer, and having stage 3 disease, which certainly makes sense. In addition, they also looked at non-breast related mortality, and these same factors also came up as potential risk factors for non-breast related mortality, and what those causes are, I will highlight in the next slide. They also did a nice job including patients living with metastatic or stage 4 disease, and again, associations for breast-related mortality included postmenopausal status, older age, being non-Hispanic African American, and having triple-negative breast cancer. So again, it makes sense that this would be the higher, the triple-negative group, for example, having higher breast-related mortality makes sense. This is what we would expect. But I think what an additional finding that this group showed is that this same group is also at high risk for non-breast-related mortality as well. So their key findings were that cardiovascular disease was actually the leading cause of mortality in the early stage non-metastatic breast cancer population, followed by secondary malignancies. And in the metastatic group, subsequent malignancies and cardiovascular disease also led the way. So as we kind of think about competing mortality contributors to our patient population, again, that more holistic look at other contributors is important. These findings are not surprising, given that, as we also heard in the last session, that cardiovascular disease is actually the leading cause of death in women, both in the US and worldwide. And as we heard, there are shared risk factors between cardiovascular disease and breast cancer. This is a global burden, not unique to the US, and there are multiple pathways that contribute to additional cardiovascular disease mortality. So the key question is, how can we optimize care? And there is, that we have strategy for primary and secondary cardiovascular risk reduction. And as kind of the previous set of abstracts highlighted, optimizing metabolic health, body composition, and fitness are definitely key features. The how we actually implement this in actually real-world complex healthcare settings has been our challenge. Moving on to the second abstract, led by Dr. Sanf and Dr. Pushtai and this SWOG Cancer Network. S1207 was a national multi-center study. This was pre-CDK4/6 inhibitors, asking the question whether the addition of mTOR inhibitor everolimus to standard of care endocrine therapy improved outcomes. Previously reported that there was no benefit to the addition of everolimus, but the investigators did a nice job of further exploring the placebo part of this arm to further understand kind of outcomes in this group. Treatment completion rates were 48% in the everolimus group and 73% in the placebo group. As we look at toxicities, as expected, the patients who actually received the targeted intervention certainly had higher rates of toxicity with higher rates of stomatitis and fatigue. But if you kind of look at the right-hand side in terms of the placebo group, they're also reporting rates of stomatitis, fatigue, and other toxicities. And breaking it down further to this kind of placebo group, the completer group versus the non-completer group, kind of in the granular counts of the different toxicities are listed. And count for count, the completer group actually was reporting higher rates of grade 1 to 2 toxicity, and I'll show you those numbers in a second, tallied. The non-completer group had a slightly higher rate of grade 3 to 4 toxicities. In terms of invasive disease survival, though, the two groups, both the completer and non-completer group, were exactly the same. However, the surprising, intriguing finding was that the completer group actually had significantly better survival, and this was after a 74-month follow-up. The odds of having overall survival documented in the completer group was 88% compared to 67% in the non-completer group. And in multivariate analysis, the only factor that really accounted for this difference was being able to complete your placebo. They accounted for disease characteristics and tumor characteristics and comorbidities and age, and none of these were as important as being able to complete your placebo arm. And so, and I do want to highlight that, interestingly, the endocrine therapy completion rate were actually also equal between the two groups. So we can't say that one group also was less likely to complete endocrine therapy. Those were equal, and really the completion of the placebo arm was the only different factor. So this highlights the concept of the nocebo effect, which is when patients receiving a placebo are actually reporting adverse toxicities. And there's a growing literature in this topic showing that patients who are more anxious, who have more medically unexplained symptoms, or have greater psychological distress are actually more likely to experience these nocebo effects. And there's actually a lot of synergy between the patient-clinician communication and interactions that can impact this nocebo finding. And prior reports have actually reported negative consequences of the nocebo effect, which can actually impact poor adherence to cancer treatment and poor cancer outcomes. We're seeing the poor cancer outcomes, but in this particular analysis, they were actually able to complete their endocrine therapy. So other contributors, other experiences within the healthcare system may have contributed to this, although the study can't currently answer this. So intriguing results. I think the science of investigating placebo and nocebo is going to be only further expanding and growing in the coming years. And I think this nice editorial and review in the New England Journal of Medicine really highlights additional opportunities that we can take back in terms of how we can improve communications about side effects and toxicity to our patients. And it also poses additional opportunities for survivorship research. Moving on to the next abstract, this is based on an analysis of the Texas Medicare beneficiaries, patients ages 65 and older, and the investigators evaluated the long-term impact of chemotherapy receipt on patient-reported balance problems and falls in older breast cancer survivors via self-report. Almost a third of these patients received adjuvant chemotherapy, and of these, most of them was a taxane. The results are listed here, and I think the most important finding for you to take away from this first table is that whether patients received chemotherapy or not, a third of patients in both cohorts actually had high rates of falls. They were reporting difficulty with balance and walking, and kind of really highlighting our broken healthcare system, the patients actually didn't recall having conversations with their provider or being given an intervention to kind of mitigate these functional deficits. But delving more specifically into the patients with who actually received chemotherapy, neurotoxic chemotherapy, this is years after that initial exposure. There were high rates of persistent chronic neuropathy symptoms in over a third of patients. It was actually interfering with function. In terms of factors associated with falls, having comorbidities, being older, were actually more likely to be associated with falls. In this particular analysis, chemotherapy was not specifically identified as a risk factor, but when they actually specifically asked about balance and walking problems, certainly receiving a taxane was associated with a greater risk. So putting this in the context of other studies, falls and balance issues are absolutely multifactorial with contributors from the musculoskeletal system as well as the central nervous system. And my group, as well as others, have really been studying balance measures as a precise predictor of neuropathy. And what we have seen is that balance measures identified by simply standing on a balance plate definitely get worse with each cycle of neurotoxicity chemotherapy exposure, and these actually track with patient-reported outcomes. So this could be a potential predictive biomarker that we are actually using in our studies. This study I think is important because it again highlights that functional deficits are common in our patient population, that we really need to do a much more comprehensive assessment, and particularly in our older population using our currently validated tools. And there's tremendous unmet need in prevention and mitigation of CIPN, but multiple randomized studies, this is not a complete risk, are currently ongoing, including a cryocompression study, there is an acupuncture study, and an Argentine tango home exercise study that we're conducting. So lots of opportunities to continue to advance this. And really, the idea of closer partnership with our onco-rehab colleagues is something that is absolutely needed in our healthcare systems. The last abstracts looked at factors and trends associated with alcohol intake. This is from Mayo Clinic with Drs. Rajput and Drs. Ruddy and team. And this was looking at patients with stage 1 to 3 breast cancer that were enrolled in the Mayo Breast Disease Registry. They were surveyed in terms of alcohol intake at year 1, at year 4, and ultimately 734 participants were included in this study. Figure 2, the year 1 marking there is actually year 4, and you can see the distribution of different amounts of alcohol intake in this particular patient population. And you can see a wide range, but the majority of patients are actually reporting 1 to 4 drinks per week, which falls under the light to slightly moderate alcohol intake category. In terms of univariate associations with alcohol intake at year 4, being a younger age was associated with persistent alcohol intake, receipt of radiotherapy, as well as having a germline pathologic BRCA1 or 2 alteration. Some additional findings, and I think I credit the group for looking at additional aspects of health promotion. Smoking status was associated with higher alcohol intake. Interestingly, being more physically active was also associated with increased alcohol intake, again highlighting that having one healthy habit does not necessarily mean that you have other healthy habits. And they also looked at psychosocial measures, including stress and trauma markers, and higher depression, and all of those were associated with alcohol intake. So body of evidence showing that there is a clear dose response curve with alcohol intake, with higher intake associated with greater breast cancer incidence as well as outcomes. And in the large cohort study of cancer survivors, both males and females are actually reporting high numbers of risky behavior, including binge drinking. And so there's lots of opportunities for health promotion. And this is something an opportunity that we can all take back to our clinics in terms of additional educational opportunities for our patients. In our NCCN 2024 patient guidelines, limitation and avoidance of alcohol is included in the context of additional healthy measures. And to wrap up in terms of our takeaways from these posters, what I would like to leave you with is that addressing survivorship domains is not solely for quality of life, but can really directly impact overall survival outcomes. As our therapeutic options become more complex, we're going to see the field of survivorship continue to grow, and I think with our aging population, there needs to be additional emphasis in this growing survivorship population. Lots of opportunities. Us oncologists cannot do this alone, so there is a critical need for multi-D collaboration and also partnership with patients. Really, the idea of patient shaming and really making health promotion and these type of, I really don't want this to be the takeaway from this discussion. This is, health promotion needs to be done in collaboration with patients, and the idea that we don't want to be creating work and stress for patients, but really creating additional creative ways where we can support our patients. And so I think kind of these partnerships are going to be key. Thank you so much.
Thank you, Dr. Lustberg. Any questions from the audience? I'll start with one then for Dr. Raj, but we'll just stick with alcohol for now. I think it's so interesting. We often see alcohol use going hand in hand with a lot of activities that we think of as healthy behaviors, right? Beer at the end of a marathon, yoga and mimosas. And, part of me always wonders, are these treating the same symptoms? So are people treating their anxieties or their mood disorders with alcohol, but also with exercise, which is perhaps a healthier way to deal? Were you able to look at anxiety in this particular study or any other work where you've been able to correlate those two?
So we looked at PHQ-9 scores, which kind of look at both depression and anxiety scales there. So the anxiety scale would have been the GAD-7 scale, but I don't believe that we looked at that in our study, but that's actually a really good point, and I wonder if we have that within our breast disease registry to analyze as a variable. But depression certainly was associated with increased alcohol intake, both at year 1 and year 4, as well as at baseline. So our year 1 data is not up here today, but we presented that at ESMO. And it was associated at all of these time points. So that's at baseline, early survivorship, late survivorship, and certainly might be something we look at for year 6 data as well.
Great. Question over here?
Yeah, good morning. Rachel Greenup, Yale. The data on older adults and falls after chemotherapy, did the authors consider looking at hearing loss associated with chemotherapy and potential vestibular damage as well? That intersected with the drugs we use to treat neuropathy is really a trifecta for falls in older adults, and it's certainly worth investigating as we take care of patients into survivorship. Thank you.
Yeah, thank you. That's a really good question. We didn't actually specifically look at hearing loss, but I agree that should be something that we would look into the database to see if we have information to look more into it.
Yeah, I think Dr. Lustberg put up the CARG breast cancer risk score looking at chemotherapy-related toxicity, and I believe hearing loss is one of those factors on there to assess someone's predicted grade 3 to 5 chemotherapy-related toxicity. Okay, I'll ask a question to Dr. Samt, because this is such an interesting study. So obviously the placebo and nocebo effect are very interesting for these patients. Have you been able to tease out whatever these additional factors may be, behavioral, follow-up to appointments, et cetera, that may account for this difference in survival?
Yeah, thanks for that question. We did look at concomitant meds, so the hypothesis being if they can't complete their placebo, maybe they have more comorbidities, maybe they're on different distributions of medications, but actually both groups took the same amount of diabetes medications, hypertension medications. They didn't look different, except the non-completer group actually had, at baseline, higher prescription opioid use. But the pain symptoms, when you look at the side effect profile, were exactly the same between two groups, so they weren't also reporting more pain. Other than that, those were the factors that we had collected for this trial. Yeah, we don't have like clinic follow-up data, but that would have been good.
Yeah, very interesting. Okay. Okay, I have a question then for Dr. Gupta. One thing that I thought was interesting, and you can correct me if I'm looking at this data wrong, was that when looking at factors that were associated with non-breast cancer-related mortality, those who received chemotherapy and radiation actually have better outcomes, which you would think we might be attributing some of this non-breast cancer-related mortality to long-term effects of chemotherapy and radiation. In this case, it appears we're actually seeing the opposite. Any thoughts there?
Yeah, so I think, we would expect to see more of these non-breast cancer-related issues in patients who've received chemotherapy or radiation. We are seeing the opposite thing here. We're seeing a protective effect. We can only hypothesize given the limitations with the SEER data, but, are these patients who took chemotherapy and that is why they have better outcomes? The other limitation is we don't have data about what kind of chemotherapy they received, how much chemotherapy they received. Did they receive one dose and then did not take the remaining like they were supposed to take the full course? So compliance, so these are all issues with, limitations of the SEER database that we could not account for.
Great. Question at the microphone.
Hi, Della Macauer from Montefiore. This is for Dr. Samt. In the randomized trial, was adherence to the endocrine therapy measured with a pill diary? So do we know if the patients who may have discontinued placebo may have been more likely to say, well, I was taking my endocrine therapy, but they really weren't taking it every day?
That's a good question. So the question is, do they measure compliance to the endocrine therapy with a pill diary? I don't actually know the answer to that. I'll have to look into it. What we do know is that the reported rates of endocrine therapy adherence were exactly the same. So they were able to continue on that even though they weren't completing their study drug. Yeah, thank you.
Okay, if there are any other questions, come to the mic. We have About 5 minutes left. The computer died. There was one question on there. I'm going to do my best to remember what it was. It was in regards to falls in the elderly, commenting that falls in the elderly are obviously common. So was there any sort of comparator group? I'm not sure if they were asking for age-matched non-cancer controls. I assume that was what they were getting at.
Yeah, so this was Medicare-linked data linked to Texas Cancer Registry. So everyone was 65 and older at the time of diagnosis. So we don't have the younger population group to compare to, but we saw that falls are pretty common. And our question was really to ask if patients receive chemotherapy at the time of diagnosis, are they let effects of this chemotherapy on falls? Which was what we were really trying to find. And even though we still saw in the data that falls are pretty common in this age, we found that there was no direct association between taxane receipt or chemotherapy use and falls 5 years out of their cancer diagnosis. Yes, but it was associated with balance problems and the rest of the fall outcomes.
Okay, great. Any other last questions from the audience? And if you submitted something online and I didn't ask, please come to the microphone. Okay, well, I'd like to thank our moderators and our presenters for a really great session. I think several points were really hit home today, one of which is that survivorship is not just about quality of life, right? We're really impacting these patients' long-term clinical outcomes too, and I think that's becoming more and more obvious to the global oncology community, and I think that's great and is really gonna drive survivorship research forward. So thank you all for contributing and for being here today, and thank you all for attending.